Well, welcome to my coming out party after 26 months doing Zoom meetings. Welcome to Cannabis and Psychiatry, the final frontier. Cue sound effects. Psychiatry, the final frontier. These are the voyages of the starship Cannabis. Its eternal botanical mission to explore strange new worlds, dimensions, and recesses of consciousness, to seek out better life and new models of civilization, to go boldly where no tardigrade, fungal mycelium, sentient being, nor split infinitive has gone before. Couple of disclaimers. Nothing I'm discussing is FDA approved. Your results may vary. As a whore of industry, I have many commercial relationships, but what I'm going to tell you is true to the best of my ability. I'll read this one. There is a world of difference between recreational studies of cannabis wherein the intention is to attain intoxication, release, or an altered state of consciousness, as compared to its therapeutic application, wherein the intent is to attain symptom relief at much lower dosages without adverse events, including psychiatric symptoms. To briefly introduce the endocannabinoid system, it all began with a plant we call cannabis. It produces the glandular trichomes and, of course, THC. It works analogously to the endogenous cannabinoids, particularly anandamide, both as weak partial agonists at the CB1 receptor. But there are many other components to the system that we'll discuss in another talk. The CB1 receptor, where anandamide and THC work, is densely packed in the central nervous system, particularly in limbic areas that subserve emotional function. It also is very important in regulating the release of glutamate and GABA in particular, so is neuromodulatory, especially on mood. What we know about cannabis extends back at least 4,000 years in written documentation. On the right, you see a tablet from the Sumerians in what is now Iraq. And there were various descriptions of what we believe to be cannabis, including this key line: for and against panic, which is a 4,000-year-old representation of the biphasic dose-response curve of THC. A little is anxiolytic, too much is anxiogenic. Just a couple of historical references to continue. This is from the oral tradition in China, 2700 BCE. Ma Fen, taking much of it, one may make one behold ghosts, which is the Chinese term for hallucinations, and frenetically run about. Protracted taking may make one fat, strong, and never senile, a neuroprotective effect. From the Atharva Veda in India, 5 kingdoms of herbs headed by Soma, and including Bhanga, that may release us from anxiety. From the Persian in the 18th century, Makhzan al-Adwiya, it is said that bhang is one of the best of God's gifts. It quickens the fancy, deepens thought, and sharpens judgment. This is far from reefer madness. Now, numerous times you'll see slides from this key paper from 2017. Yes, there's been additional information since then, but this is the best review on the subject of medical cannabis and mental health by Zach Walsh et al. We're going to start off with neurocognition. Does cannabis produce impairment? And you'll see that he separates these into therapeutic use and non-medical use. But as we'll demonstrate, the results are much milder and surprising in terms of impairment that cannabis produces and whether that remains with the individual or not. I'd like to review some studies that are very little known. These were actually sponsored by the National Institute on Drug Abuse in the 70s. And after they did several of these and the results weren't what they wanted, they stopped funding them. And these books actually disappeared from libraries. It took me years to obtain them on the antiquarian book market. This one, Jamaica, ganja in Jamaica, they looked at 60 men and had them in the hospital to do all kinds of tests. They were using 3 spliffs a day. We'd consider this low potency, but I don't know where they were getting their spliffs. There was better material available in Jamaica, as I can attest to personally at the time. But the key thing for today is that there were no significant differences in neuropsychological tests. The users of cannabis actually had increased Wechsler adult intelligence scales on the digit span, something you'd think would be hard to remember if you're high. There was a study from Greece with hashish, again, moderately low potency, but these are people that used a lot. There weren't a lot of electroencephalographic changes. On the neuropsych testing, users were better than controls on the WACE, similarities, digit symbol substitution, and verbal IQ. These observations do not provide evidence of deterioration of mental abilities in the hashish users. Another one from Costa Rica, again, relatively mild quality cannabis, but high volume of usage. Ultimately, enough THC was getting in. There were no immunologic or endocrine changes on neuropsych. Again, quote, we failed to uncover significant differences between user and non-user groups, even in those subjects who had consumed cannabis for over 18 years. In this study from Jamaica, Melanie Dreyer, who became the dean of nursing school subsequent to this, working men in ganja, in this study, she showed that the work capacity for working in the fields in a hot, humid environment was enhanced by cannabis. And very interestingly, among Rastafarian women who used high volumes of cannabis, ganja, but did not use alcohol, their children actually were advanced in their neurodevelopment as compared to control children. A study that our group did in Missoula, Montana back in 2001, we took 4 patients from the Compassionate Use Investigational New Drug Program that got legal cannabis from the government. Again, relatively low potency by modern standards, but they were using upwards of 9 grams a day. And these are the profiles of the patients. These are all the tests we subject them to, excuse the 20-year-old technology, but you see all the neuropsychological tests that we did. Quite an intensive investigation. In those findings, all 4 patients had mild difficulty with attention and concentration. However, they were medicating the whole time that we were doing this, so this is not surprising. There was at least minimal impairment in acquisition of complex new verbal material, but the important things, higher level executive functions were totally within normal limits in 2 of the 4, and none were depressed. I'll demonstrate that later. It was the judgment of the neuropsychologist that there were no attributable sequelae to their cannabis usage. To follow up in 2018, and these are the ages, patient A, B, and D had lost access to NIDA cannabis, but patient A continued daily use from other sources, possibly of higher potency. Patients B and D were reported cognitively intact by the nurse on the study, was Mary Lynn Mathry. And I interviewed patients A and C, and as a neurologist, I can say that they were quite sharp mentally. Patient C is an active vice president of an investment firm. So people rely on him to manage their money. Now, some studies. Pope et al., and this is an older study, but it's very well done. They looked at current and past heavy users of cannabis with light past users and got neuropsychological tests. There were some cognitive deficits in the current heavy users that persisted for a week, but were totally gone by 30 days. Quote, our findings do not support the hypothesis that long-term heavy cannabis use causes irreversible changes. Oh, excuse me. Igor Grant, who is the chairman of psychiatry at UC San Diego, did this meta-analysis and intensively looked at published studies and crunched the numbers on them. Quote, the results of our meta-analytic study failed to reveal a substantial systematic effect of long-term regular cannabis consumption on the neurocognitive function of users who were not acutely intoxicated. And then a key finding, differentiating this, quote, recreational usage from therapeutic usage. Quote, these findings are not likely to generalize to more limited administration of cannabis compounds as would be seen in a medical setting. In other words, medical patients used less and would be less likely to have impairment. More recent study with very big numbers, over 2,000 cannabis users, young age, 20, compared to almost 7,000 controls. Looking again at meta-analysis of studies of neuropsychological function. In studies examining abstinence of greater than 3 days, there were no significant difference from abstainers. The overall effect size was very low in terms of any reduction of cognitive function in frequent or heavy users. Ultimately, any changes between the groups were below 1/3 of a standard deviation, meaning from a statistical standpoint, there's no difference. Quote, previous studies of cannabis in youth may have overstated the magnitude and persistence of cognitive deficits associated with use. Reported deficits may reflect residual effects from acute use or withdrawal. And, quote, these results do not support a heightened risk for poor cognitive outcomes in cannabis-using adolescents compared with adults. Does that mean it's fine for teenagers to do multiple bong hits after school instead of doing sports or studying? No, nobody was saying that. However, in terms of damage, there's no evidence for the same. My colleague Kirsten Müller-Fall in Germany has studied Tourette syndrome extensively. They were using a pure THC preparation. If there were going to be a problem, you'd expect it to be related to that. However, they saw no detrimental effects on neuropsych function. Our friend Donald Abrams did a study of pain and HIV. This required smoking of nitro cannabis. All the patients had prior experience with cannabis, and it was helpful in decreasing acute pain. The problem was smoking isn't the best way to treat most medical conditions because of the rapid increase in pharmacokinetics. And as you see here, there was 25% anxiety, 54% sedation, disorientation 16%. This is not the kind of profile that the FDA is likely ever to approve. Turning to some studies of nabiximols or Sativex, which is an oral mucosal spray with equal amounts of THC, CBD, scattered cannabinoids and terpenoids. This is a study of neuropathic pain and multiple sclerosis, 66 patients. There were no significant difference in Hamilton anxiety, depression scores, and in neurologic disability scales. There was improvement in selective reminding portion of the brief repeatable, misspelled, battery of neuropsychological traits. So that was encouraging. In this comparison, we looked at long-term use of nabiximols, Sativex, as compared to smoked cannabis in the Dutch and Canadian programs over the long term. The hot colors are the smoked cannabis, and the cool colors are nabiximols. As you see, the side effects, including psychiatric associations, were much higher in smoked cannabis, and these were both medical populations. Again, looking at nabiximols, the difference between early studies with fast titration and higher allowance, they found that more than 12 sprays, which would be about 32.4 milligrams of THC a day, above that, you had more side effects than benefits. When a slower titration with limits were placed on the studies, you see that dizziness, fatigue, somnolence, et cetera, were cut markedly. A very comprehensive study was done post-marketing of nabiximols by Recand et al., and this was done in Europe. They looked at 150 patients in clinical trials and 900 post-marketing. The doses that were used in practice were actually lower than in the clinical trials. There was one case of suicidal ideation, but that person was on placebo. Long-term treatment with THC CBD spray was not associated with cognitive decline, depression, or significant mood changes. Looking at driving, another area of contention, there was only one small decrease in visual pursuit, not statistically significant. You see that all the other parameters of driving were improved, and determination was statistically significantly improved. These patients were better drivers during their treatment, after their treatment of multiple sclerosis with nabiximols. Again, neuropsychological testing, this is the PASAT, the PACE, auditory serial addition test. Glad I got that out. No significant difference, placebo or after treatment. But these patients with multiple sclerosis spasticity were clearly better. The general impression of change by patients, physicians, and their caregivers. Side effects. In terms, one person at 40 had significant psychiatric side effects, and 0 in this cohort had any suicidal ideation. A study in children from Israel, this was actually done with delta-8 THC, but this was pure. It would be unlike preparations currently in vogue in this country. They treated 8 children with hematologic malignancies. There were 400 in total, 80 dose applications with almost total abrogation of the nausea and vomiting associated with the chemotherapy. Their doses were actually very high compared to what happens in adults, and this points out that children under 10 are highly resistant to psychoactive side effects of THC. Maybe kids are naturally high. We've got a bunch of studies, observational work from Israel, and this was cannabis and autism, 180 patients, mostly taking an oil, CBD predominant, but with, a decent dose of THC 3 times a day. After 6 months, the vast majority were continuing treatment. Their moods were improved in almost 2/3, improved activities of daily living, good sleep, and concentration. 80% were significantly improved. This is an old study of Sativex, and you'll see that in almost every instance, in a variety of different conditions, there was improvement in sleep parameters, and almost every study of cannabis used therapeutically will have similar findings. Now let's look at post-traumatic stress. Previous research has been done in either animals or humans. Work in animals showed extinction of aversive memories, which are a hallmark of the disorder. Also, stress-induced analgesia was demonstrated, reduction in pain, and Blewett posited the idea of a central anandamide deficiency predicting stress-induced anxiety. So let's dig into specific studies. This is Walsh's review of the data available then. A substantial portion of people with PTSD use cannabis with good outcomes, particularly improving sleep and reducing nightmares. One of the effects of THC is reducing somewhat rapid eye movement sleep of dreaming and nightmares. So this is quite sensible. Matt Hill looked at World Trade Center survivors, compared the people who developed post-traumatic stress to those who didn't, and also normal controls. And they looked at anandamide levels. There was a negative relationship between the anandamide levels and intrusive symptoms. They felt that the results showed a good correlation of lower anandamide levels to increased CB1 receptor binding sites in the central nervous system. In other words, providing evidence for clinical endocannabinoid deficiency in PTSD. This was an imaging study done with positron emission tomography, again in post-traumatic stress versus trauma patients that didn't have PTSD, again, healthy controls. This is complicated, but the CB1 selective radioligand showed a higher volume of distribution with lower anandamide tone in PTSD that was highly statistically significant over healthy controls and the trauma-exposed controls that didn't have PTSD. And they went on to suggest that agents increasing anandamide availability were possible therapeutics. That would include things like cannabidiol and cannabigerol. What Walsh et al. Said about depression, and there were improvements noted. There have been allegations of an association of cannabis use with depression, but no evidence specifically of causation, and this is always an important distinction. So let's look back at the chronic use study. Again, 4 patients, middle to age to older, who were using many grams of NIDA-supplied cannabis a day. They had very bad diseases that would make anyone depressed. 2 of the 4 patients had been addicted to opioids, 1 intravenous opioids, in the past. None were taking anything of the kind. So if we look at the Beck Depression Inventory 2, mild depression is 18, moderate 27, severe 34. We had patient A with a score of 6, not depressed, and the other 3 scores of 0, hardly at all depressed. This is a study I wish I'd done. I had this idea 20 years ago, but no way to look at it. I was struck by the fact that electroconvulsive treatment, shock therapy, is still effective in intractable depression where drugs haven't worked. So what does it do? Well, people's mood improves, number 1. Number 2, when there's too much treatment, they have short-term memory impairment, usually temporary. What does that sound like? It sounds like cannabis. So, I thought if we could test these people, their cerebrospinal fluid with spinal taps, lumbar punctures, we could demonstrate that, but we'd never get it through an institutional review board, ethics committee. Well, they were able to do it in Germany. So they looked at 12 depressed patients who had cerebrospinal fluid exam before and after electroconvulsive therapy. The ECT increased anandamide levels significantly and nearly significantly on the 2-arachidonoglycerol. And the number of treatments correlated with these kinds of differences. Their conclusion was that electroconvulsive therapy modulates the endocannabinoid system to alleviate depression. Well, the whales are calling me, but they'll have to wait. Looking at the issue of psychosis, everyone knows that too much cannabis can make people crazy temporarily. But it's been much more controversial as to whether you generate de novo cases of schizophrenia related to cannabis usage. Best evidence is if there's an underlying susceptibility, it will unmask it earlier. In this study done in the United Kingdom, they looked at 600,000 patient visits that represent 2.3% of the entire population of the country. What they noted was the incidence and prevalence of schizophrenia was stable or actually declined somewhat in the 10-year interval 96 to 2005. And this is keeping in mind that there was an 18-fold increase in cannabis usage between 1972 and 2002. So schizophrenia incidence down, cannabis use up. Doesn't seem to indicate a problem. Quote, the most parsimonious explanation of the results reported here are that the schizophrenia psychoses data presented here are valid, and the causal models linking cannabis with schizophrenia psychoses are not supported by this study. Another analysis from England, they looked at male heavy users of cannabis and looked at the number needed to prevent a case of schizophrenia. And this ranged from 2,800 to 4,700 people, depending on their age. In females, it was somewhere between 5,000 and 10,000 people. You'd have to stop from using cannabis at all to prevent a case of schizophrenia. That's hardly convincing as an association. How about therapeutic use? Well, there have been 2 randomized controlled trials of pure cannabidiol in schizophrenia, both phase 2, using very high doses. In this one by Levica et al. In Germany, 800 milligrams of cannabidiol a day compared to the atypical antipsychotic amisulpride in 42 patients over 4 weeks. There were improvements in positive and negative syndrome scores in each, but the negative symptoms were notably better on cannabidiol, and there were many fewer side effects and prolactin elevation. The atypical antipsychotics are tough drugs that produce weight gain, sometimes diabetes. Patients don't like them, and we have a real possible alternative here. The dosing probably could be a great deal lower with a more complete whole cannabis extract. Another study from England, this time 1,000 milligrams of pure CBD divided twice a day over 6 weeks. And they were compared to control patients who were on standard antipsychotics. Positive psychotic symptoms decreased on CBD. Clinicians' ratings favored CBD over conventional agents, and motor speed also improved on CBD. How about acute craziness, what's called a toxic psychosis from excesses of THC? In this, I compared Marinol, which is pure synthetic THC, which has been known to cause toxic psychosis, paranoia, delusions in patients with as little as 10 or 15 milligrams of pure THC. In this study by Sellers, we had to give 18 sprays all at once to show that there were no heart rhythm abnormalities. And there were 4 episodes of toxic psychosis out of 260 exposures. So that would be 48 milligrams of THC sometimes in people who'd never used cannabis at all. But everyone was fine the next day. That's the difference that cannabidiol and terpenoids make. Walsh on anxiety, 8 cross-sectional studies of medical use, 2 non-medical use. In the non-medical use, there was a small positive association between cannabis use and anxiety, but again, no evidence of causation. A lot of work on cannabidiol was done in Brazil. This was another study with pure CBD, and they were looking at people with social anxiety, something a lot of people have. A small study, normal controls, and 24 with social anxiety. Some got CBD and some didn't. But they used 600 milligrams of CBD. That'd be an awful expensive proposition to use regularly. CBD pre-treatment, before trying to make them anxious, significantly reduced anxiety, cognitive impairment, and discomfort in their public speaking performance. I'm speaking today without benefit of CBD or anything else. I've just gotten used to this over time. Study of Feingold, looking at cannabis use in people with anxiety disorders. They started with a large sample, 3,723 Americans. A small percentage had a diagnosis of anxiety disorder and were using cannabis regularly, but there was no significant difference in anxiety remission rates compared to other users and non-users. No significant difference on suicidality, on quality of life. Emotional and mental health subscales and functioning scales were significantly higher in the cannabis users than people who did not use it. In this study in Canada, again, big numbers, 888 people with anxiety, looking at their use rates of other drugs. 61% had completely replaced a drug that was prescribed for their condition. Obviously, the most frequently replaced were antidepressants and benzodiazepines, as you see. What about abuse? This was from the clinical trials of nabiximols, Sativex that were done in this country. And this was the only episode in some hundreds and hundreds of patient exposures, attempted abuse of nabiximols. But the perpetrator didn't get inside the bottle, and there he is, a little white dog. So there was no abuse or diversion in the entire program of 3 phase 3 clinical trials. Historically, interesting relations between cannabis and addiction. J.B. Madison, who worked in St. Louis in the 19th century, he used cannabis to treat cocaine, chloral hydrate, and opiate addiction. Quote, "In these often it is proved an efficient substitute for the poppy." Crothers wrote the key textbook on addiction from the early 20th century. The only mention of cannabis was not as a drug of abuse, but rather as a treatment for other addictions. Quote, "Cannabis indica can often be used with very good effect in treating morphinism, especially the temporary removal of the worst symptoms." Can someone use cannabis medicinally if they've had a prior problem with cannabis or opioids? Well, yes, they can be used quite successfully together, even in people who've had medical dependency on one or the other. But after a point at which the patient has improvement in their symptoms, most notably pain, it's reasonable to taper the opioids. But many patients do this on their own, and clinicians here will attest to this. If someone has a clear cannabis use disorder or displays tolerance to high doses, Dustin Sulak has a resensitization procedure, which you can find online. Basically has them stop for just 48 hours and resume at half the prior dose, and usually with equal protection against the problem for which they've been treating. These are, again, from nabiximols studies. Addiction usually comes from some kind of intoxication. Well, if you're not intoxicated, you're highly unlikely to become dependent. On the bottom, you'll see intoxication scores of nabiximols in clinical trials compared to placebo. 20 on this scale, visual analog scale, is you feel something. 80 is what a person usually wants if they're using cannabis recreationally. And you'll see that we're looking at single digits, no significant difference between placebo and nabiximols. Addiction usually implies dose escalation. On top, we see number of sprays a day of nabiximols over a year and a half. And what you see is the slope actually goes down a little. Over time, people find that they do with less and don't increase their use rates. Another study from Israel looking at pain and quality of life. 176 Israeli patients with pain that qualified for treatment with cannabis. Average of just 1.5 grams a day, mainly by smoking. Pain symptom scores improved along with family social disability, emotional disability, outcome satisfaction, and sleep problems. Of the 73 patients who were on opioids, 44% discontinued them. That was highly statistically significant. And the median oral morphine dose equivalence decreased from 60 to 45 milligrams a day. Obviously, less likelihood of problems related to that. Benke et al. Looked at opioid usage, again in patients with chronic pain. 118 patients. There was a 64% reduction in opioids and a 45% increase in quality of life measures. Some of that could be related to fewer side effects related to the opioids, but we'll take it any way we can get it. The brilliant Stacy Gruber, who we'll be hearing from tomorrow, did this study. She always has funny titles. The grass might be greener. They looked at patients who were using cannabis medicinally for a variety of problems over 3 months. There were marked improvements on depression on the Beck scale, impulsivity, sleep, quality of life, and energy, fewer physical limitations. For patients who are on opioids, the intake was reduced almost by half. Again, almost by half on benzodiazepines, a quarter on antidepressants and mood stabilizers after 3 months of treatment. And again, some improvement in cognitive function could be because of reductions of other drugs. Another observational study from Israel, these are patients with cancer and associated pain. Of the 344 patients that were on opioids beginning the study, 36% discontinued them, and only 9.9% decreased their dosage, only 1.1% increased it, and 51% remained stable. Meanwhile, anxiety and depression declined 84.2%. Another study from Israel, this time in fibromyalgia. 26 patients getting a mean dose of 26 grams a day, so less than 1 gram a day. 26 grams a month, less than 1 gram a day. 46% found their work capacity increased, and there was substantial opioid sparing and decreased use of adjunctive drugs. You see under strong opiates a p-value of 0, meaning no chance this was a chance finding. This was an animal study from Xi et al., looking at CB2 receptor modulation of cocaine activity in mice. CB2 is expressed in the ventral tegmental area and nucleus accumbens, dopaminergic neurons that pertain to addiction. So when CB2 is activated by the synthetic agent, it either dosed systemically in the nose or microinjection into the nucleus accumbens and inhibited dopamine release and cocaine self-administration. A natural agent in cannabis, caryophyllene, is an agonist at the CB2 receptor, and we believe would do the same thing. This is from a prior paper, just some suggestions on what could be used from cannabis to treat different conditions. For depression, small amounts of THC, CBD, CBG, and limonene. For anxiety, CBD with limonene and linalool. I would add something we're going to see in a moment. For agitation, Alzheimer's disease, various things help: THC, CBD, limonene, pinene, linalool. For sleep, many different agents. And for addiction, particularly CBD and caryophyllene. To finish up with some new data, give you something new. This study was published last year. This was done with my colleagues at the Washington State University and UC San Diego. It was the first study to systematically examine cannabigerol in humans. 127 patients. They were required to report only on material that was at least 50% CBG. So some had pure CBG with terpenoids. Some were mixed with THC. You see this long list of conditions that people used to treated with cannabigerol. 51% said that their use was medical. Only 6.3% claimed it to be recreational, and for 36.2%, both. The most common conditions treated were anxiety, pain, depression, and insomnia. But a whole bunch of other things were tried. What happened? Well, the majority of conditions were much or very much improved. The highest efficacy on a percentage basis were for endometriosis, inflammatory bowel disease, and irritable bowel, but those were low numbers. Among the high numbers, the insomnia, you see a p-value of 0.001, one chance in 1,000 that this was a spurious result. For depression and anxiety, again, p-values of 0.001. In every instance, patients felt that CBG was superior to conventional medicine that they'd used to treat their conditions. And a lot got off of those other medicines. I'll close by saying this bugger you see depicted here is still around. If you don't believe in vaccines, please be advised that I'm a Jewish space laser operator. Thank you for your attention, and I hope we've left a little time for questions. From the floor. I think that they've got microphones set up if you'd like to step up. Oh, bad sign, shy audience. Cello.
Hi, thank you. And thank you for all of this. Could you please let these folks know a little more specifically about how cannabis helps dementia?
Sure. I wrote a paper basically on cannabis and neurology and its promise. It really didn't fit into this talk well, but there have been extensive studies that support the idea that both THC and CBD might actually be neuroprotective in Alzheimer's disease by preventing the buildup of toxic proteins in the brain that are one of the hallmarks of the pathology of Alzheimer's disease. We also know that both of them help a great deal symptomatically in treating dementia. Our friend Jeff Hergenrather treats a bunch of patients in a nursing home in Sonoma County. The nurses love it. The families of the patients love it because the patients are more tractable. They require less nursing care. They sleep. Some of them sing. Some of them are showing resumption of skills they'd already lost. So there is practical information to support the use of specific cannabis-based treatments in dementia for both symptomatic benefits and also as possible neuroprotective agents. So thanks for the question.
Thank you so much.
I can't see because there's light in my eyes, but please go ahead.
Hi. In your presentation, you referenced some studies. There was a NIDA-issued cannabis for these studies, and I wondered the amount of THC that was actually administered or was a part of that study. So can you estimate what is the amount of THC in the National Institute of Drug Abuse issued cannabis?
Yeah, it's a good question. It's a complex one. So, the stuff was under 4% that they utilized, but high volumes, 9 grams a day. You can start calculating, even with a reduced bioavailability in joints. At a minimum, it had to be in the 30 to 50 milligrams of THC a day. I'd say minimum. But the patients had almost complete tolerance to intoxication. We could demonstrate minor differences when they were actually smoking on the neuropsych tests, but they all functioned really well and far better than they had before such treatment. We're talking about miserable diseases. To get into this program, you had to exhaust every medical possibility and prove that to a skeptical government. So it was a high bar indeed.
Very helpful. Thank you.
Thank you, Ethan. Wonderful presentation. I'm over here.
I recognize the voice.
The need for safe and effective psychiatric treatments is probably more now than ever. And the field of psychiatry, from my experience, is the most reluctant to even consider cannabis as a useful option. Meanwhile, physicians have the highest rate of suicide among any profession. So we're also miserable in this field, not us specifically, but our colleagues are. How do you see this information and this treatment making its way to the patients that need it? How do you see at a macro level the healing of this healthcare approach to mental health?
Yeah, it's really tough. I mean, I've been doing this for 26 years, and I have to say that the roadblocks to research remain largely the same as they were in the late 90s when I began this, which is a very sad state of affairs. We shouldn't be ceding the ability to investigate cannabis medicinally to other countries. Even now, Sue Sisley did a recent study of post-traumatic stress. She had to use NIDA cannabis. The study was not successful. Everybody knows that cannabis can be used successfully to treat PTSD. So it's a severe mismatch here. And it remains the case, if I have a preparation that I think is going to be good for treating a specific condition, and I want to get FDA approval, can't be made in this country right this moment. This explains why, for a majority of the last 26 years, I've worked for foreign companies. It's not the way it should be. I think we have to be doggedly persistent. I think I have been, but I'm 70 years old now, and I get tired from time to time. So we need young physicians who are dedicated, like Drs. Sulak, Goldstein, and many others, to carry on. But It just takes dogged determination. That's it. Hopefully some legislative change, but I wouldn't be hanging my hat on that, not the way things are going.
Dr. Russo, can you cite some studies of the effect of cannabis on bipolar disorder types 1 and 2?
Yeah, that's a tougher one. Bipolar is hard to treat with anything. We hear reports of benefit in specific patients. Everything is dependent on the preparation. I would really have to think about, I think it needs to be individualized. With bipolarity, there are just vast differences in the cycles that people have. Some are rapid cyclers, some have predominantly depression, some are predominantly manic. For better or worse, a lot of people with bipolar disorder don't want to medicate because they like how they feel when they're manic. So it's a very tough problem. It doesn't mean it shouldn't be investigated. It's just right now we have only anecdotal evidence.
Thank you very much.
Sure.
Hi, Ethan. Other side. No worries. Just a question kind of for the room. As far as the problem of studying whole plant or full spectrum products, what do you think about, so you can do a clinical trial of Marinol. Clearly, it's done regularly. You can also use full spectrum hemp extract, so the below the 0.3% THC, and that's acceptable. Can you dial in the dose of THC that you want, mix that together with a full spectrum hemp extract as an excipient, combine that product, pretty much approximate a full spectrum cannabis product, and do a study with that? And I would tell you that I've talked to the DEA and the FDA on this, and they have gone ahead and said, yeah, you can do that legally. They don't have a problem with that. What do you think about that as a potential way through the regulatory nuisance of the federal government?
Well, what I'd say initially is you shouldn't be having to jump through all these hoops. But beyond that, I'm a firm believer in full spectrum products. I'm also and you can mix and match. For example, it's not commonly known that nabiximols is a combination of a high THC chemovar and a high CBD chemovar. That's allowed as long as it comes from one species, i.e. cannabis sativa. I have to make a bold statement, which is I think that very few studies of cannabis used therapeutically have used optimized preparations. I have strong opinions about what you need for a given condition, and the profiles of the materials used have rarely jibed with what I think is going to be best. But again, I think the best approach is look at the disorder, what is needed, what is the combination of cannabinoids, keeping in mind that if you need THC, like with PTSD, you've got to have THC for it to be effective. You need to suppress dream and nightmare activity to some degree, but tiny doses are necessary, and maybe with higher doses of CBD, cannabigerol, and with a good terpenoid profile. That's an ignored aspect of this. We have studies underway that we hope will definitively show the contributions and synergy between the terpenoids and THC. So I'd like to see a lot more thought go into the preparations and not just some generic cannabis that comes from a barrel at NIDA.
Hi, Dr. Russo. Thank you for your speech today and all of your hard work. I'm very fascinated by this tolerance in adolescents under 10. I was wondering if you could elucidate upon any studies on, longitudinal studies on psychiatric effects of use of cannabis from the age of 10.
I'm not aware of any evidence of, particularly in therapeutic use, of any kind of neuropsychological sequelae. And again, the evidence from, if we look at the recreational data that we saw with much higher doses, and it would include people that started at age 10 or 12, there was no evidence of significant adverse effects that were attributable to it. That doesn't mean everyone should do it. It means that cannabis is a reasonable and can be a safe alternative for treating serious medical conditions of children. Again, under 10, it's not just that one study that showed the phenomenon that children are highly resistant to problems at a young age. That was noted back in 1840 by O'Shaughnessy in India. They had a child, infant in fact, with convulsions that took a dose that would have laid out an adult. So it can happen. You know, this idea that we've got to protect the children, usually you're treating diseases that are far worse and more dangerous to their lives than cannabis would be in any preparation.
Thank you.
So piggybacking off of what Alex said, where's cannabis's role in treating this sort of pediatric mental health crisis that we're going through? I'm working in a pediatric emergency department. I can tell you that we're dealing with more and more issues, and I know cannabis has a role. I was curious to get your take on it.
I'm sorry. The monitors are in front of me, and it's a little boomy. If you could repeat.
Sure, sorry about that. So essentially, we have a mental health crisis, particularly amongst pediatric population, and I wanted to know your take on where exactly cannabis plays a role, and if it is CBD dominant, type 2, type 3, et cetera.
Sure. You know, at this point, cannabidiol as a pure preparation, Epidiolex 97% CBD, is FDA approved for Dravet and Lennox-Gastaut syndromes and treatment of seizures and tuberous sclerosis. Nobody objected much to that. However, Pamplona indicated through his meta-analysis that similar results could be obtained with doses that were of CBD that were about 80% lower when it was a full spectrum preparation. You know, using 1,500 milligrams of CBD a day is prohibitively expensive. I think that we have to be more reasonable about the cost-benefit ratio, and whether it is intractable seizures, autism, any serious disorder of childhood that cannabis might help, I think, is a proper area to investigate, is my feeling.
Specifically related to mental health. I was curious what your take was.
Okay, well, you know, if we have a self-destructive autistic child, you know, that is on the verge of being institutionalized, yeah, they should be treated with something that's going to work. Conventional medicine is notoriously poor at helping those children. And Dr. Goldstein in particular can attest to the benefit she's seen in that kind of context.
Thank you.
Thank you, Dr. Russo. Judge Thompson, I'm a newbie to the conference and appreciate the evolutionary aspect of the clinical studies that you presented. I guess my question is from the health care utilization, health services perspective. Is anybody doing work to document reduction in healthcare utilization to quantify the cost effectiveness that you just mentioned and make the argument for broader support?
Yeah, there's been good evidence, particularly the studies of Bradford and Bradford, looking at Medicaid and Medicare populations and use rates of narcotics. Marked reductions have been noted in states with legal medical access, also a reduction in overdose deaths. Now, you have to be careful there. The deaths have clearly gone down. You can't claim causation, but it's a reasonable inference that the reductions might be due to cannabis availability, and many of us believe that to be the case. Now, I'm not sure how, I'm we're cutting into the break by a bit. I will defer to the powers that be to say when I should stop. We're done? Okay. Thank you again for your attention.